A very good afternoon to one and all. It is my pleasure to welcome our beloved Dean Madam, Dr. Dimple Padave, our guest speakers for the day, respected heads of all the departments, and all the postgraduate trainees, undergraduate students, and my dear friends. As the saying goes, when there is no place for scalpel, words are the only surgeon's only tool. Beginning the day with this, we are meeting today online to celebrate the International Oral and Maxillofacial Surgeons Day. The International Association of Oral and Maxillofacial Surgeons observe 13th February every year as a day of Oral and Maxillofacial Surgeons Day to commemorate its first meeting held on this day in 1969. However, 13th February being a holiday this year, we are celebrating it today on the 11th of February. This day is celebrated with great enthusiasm throughout the world to create awareness about possibilities of maxillofacial surgeries and their experts. As a surgeon, we should build a culture of prevention so that we are a nation that is good as preventing illness as we are at treating it. Department of Oral and Maxillofacial Surgery, Government Dental College, Mumbai has organized patient awareness program today in the department from 11 a.m. to 1 p.m. and we have almost counseled around 100 patients regarding oral illness and gave an overview about a specialty. Along with this, we are conducting this webinar to educate our fellow colleagues on what oral and maxillofacial surgeons can do and on basics of diagnosis and prevention of oral cancer, as early diagnosis reduces the morbidity of the patient. I may now request our head of the department, Dr. Prajulit Kende sir, to brief on today's occasion.
A very good afternoon to one and all. With the remembrance of Goddess of Knowledge, Mata Saraswati, late Dr. K.L. Shauri, the first principal of Government Dental College and Hospital, Mumbai, late Professor Dr. M.S.N. Jeanwala, father of oral and maxillofacial surgery of India, late Dr. S.S. Khera, the first head of the Department of Oral and Maxillofacial Surgery, GDC Mumbai, late Dr. I.C. Dudani, an adorable teacher in the field of maxillofacial surgery, our beloved Dean Madam, Dr. Dimple Padave, and today's acting Dean, Dr. Ishwaran Sir, respected all the heads of the department, respected guest speakers, delegates, students, and my dear friends. 13th of February is observed as an International Oral and Maxillofacial Surgeons Day. This day is celebrated to commemorate its first meeting held in 1969. Since the earliest days of the specialty, oral and maxillofacial surgery has expanded its scope of practice by leaps and bounds. On this day, remember our late Dr. Daniel M. Laskin, who was a great author. Everybody knows him. He was very famous. He has written books on oral and maxillofacial surgery. Very well-renowned oral and maxillofacial surgeon, excellent person. We have lost this gem of oral and maxillofacial surgery last year. On behalf of Government Dental College and Hospital, Mumbai, and Department of Oral and Maxillofacial Surgery, I pay my homage to Dr. Daniel M. Laskin. Maxillofacial surgeons treat hard and soft tissue injuries of face, tumors of mouth, jaws, and neck, oral cancer, congenital facial deformities. Also, pure aesthetic and cosmetic surgery also comes under our purview. But most of the medical and as well as our dental fraternity, as well as our patients, they are unaware of the surgeries which are carried out by the oral and maxillofacial surgeons. Oral cancer today has emerged as the most common cancer in India. Apart from treating oral cancer, we should also try to prevent it as well as diagnose it early so that major ablation can be prevented. Thus, our today's webinar, our objective will be discussed about the role of maxillofacial surgeons in our field, as well as we will be having a talk on oral cancer prevention and how to diagnose it early. Hope you will learn a lot from our guest speakers, and please feel free to ask them your queries. So on behalf of GDC Mumbai and Department of Oral and Maxillofacial Surgery, I extend my best wishes to all the oral and maxillofacial surgeons in India as well as around the globe for the International Oral and Maxillofacial Surgeons Day. Thank you very much for your kind attention.
Thank you, sir. Our Dean Madam is on leave. I now call upon our Acting Dean, Dr. Iswaran sir, to share his insights.
A very good afternoon to one and all. On behalf of GDC Mumbai, I welcome our guest speakers, Dr. Sagar Vaishampayan and Dr. Hitesh Sanghavi, all the HODs, teachers, faculty members, students for this webinar. As sir has already explained, this program is being organized to commemorate the International Day of Oral and Maxillofacial Surgeons, which falls on 13th of February every year. Everyone of us know about the vast scope of oral surgery. Right from exodontia to major reconstructive procedures, trauma, subject is very vast. And aptly, today we have the topic given to Dr. Sagar Vaishampayan, the scope of oral surgery. I am very glad to announce that Dr. Sagar Vaishampayan is also an alumni of GDC Mumbai. I welcome you, sir, to GDC Mumbai once again. And I'm sure your talk is going to enlighten all the young students over there about the vast scope of the subject. Oral cancer is another major problem that is affecting our people, and it creates a lot of morbidity and mortality also. The management of oral cancer is multidisciplinary, and maxillofacial surgeons have got a wide role in this. And once again, I am happy to announce Dr. Hitesh Sanghavi, who is also a GDCite. I welcome you, Dr. Hitesh, and I'm looking forward to both these talks today. I also would like to congratulate Dr. Kende sir for organizing this wonderful program, and I wish it a grand success. Thank you.
Thank you, sir, for your kind words. I would like to begin with the main attraction of today's events, that is the lecture series. The first oration is going to be presented by Dr. Sagar Vaishampayan, sir, who is going to brief us on the topic, the things oral and maxillofacial surgeons can do. I would now request Dr. Samir Khaire, sir, to introduce our first speaker, Dr. Sagar, sir.
A very good afternoon to all our viewers. It gives me great pleasure to introduce our first speaker, Dr. Sagar Sridhar Vaishampayan. Dr. Sagar, as an undergraduate student, has topped all the 4 university examinations, and he has been awarded Sanjay Gupta Award for Academic Excellence. Dr. Sagar has done his post-graduation from Government Dental College and Hospital, Mumbai. During his post-graduation as well, Dr. Sagar has topped in all specialities in both the Part 1 as well as Part 2 examinations held by the university. Dr. Sagar has also worked as a research fellow in head and neck oncosurgery, which is conducted at Tata Memorial Hospital, Mumbai. Dr. Sagar has also traveled to Germany for his training during the years 2016, when he worked at the Cranio-Maxillofacial Surgery Unit, Military Academic Hospital in Germany. Presently, Dr. Sagar is working as an associate professor at MGM Medical University, Kamote, Navi Mumbai. Dr. Sagar has co-authored a chapter, Face and Jaws, in the textbook of Hamilton Bailey. He also has several international publications to his credit. Presently, Dr. Sagar is also working as a panel consultant at MGM Hospital, Vashi, Navi Mumbai, Apollo Hospital, Belapur, Navi Mumbai, the HCS, ICS, Kup Chandani Hospital, Cooperage, the Global Hospital, Parel, Hinduja Hospital, Khar, Nanavati Hospital at Villeparle, and the Asian Cancer Institute at Sion. Dr. Sagar has several interests and expertise. He likes to work in oral surgery, oral cancer, and related reconstruction, orthognathic surgery, facial access osteotomies, craniomaxillofacial trauma, oral implantology and guided bone regeneration, benign jaw pathologies, odontogenic infections, and dentoalveolar surgery. Dr. Sagar, we are all eager to listen to you. I now hand over to you to begin your session, please.
Is my screen visible?
Yes, sir.
Okay. So good afternoon, everyone. It's a great honor to be back at my alma mater, Government Dental College and Hospital, Mumbai. I had the honor to work under the guidance of Dr. Prajwalit Kende sir, Dr. Samir Khaire sir, who both were my seniors during my post-graduation years. And I have gained a lot from both of them. The quick-wittedness of Dr. Prajwalit sir and the methodic and extremely systematic, disciplined way of life from Dr. Samir sir is what I always want to imbibe. Good afternoon, everyone. And today's topic, when Dr. Told me he wanted a talk on the basic scope of oral and maxillofacial surgery, meant for the students who want to take up oral and maxillofacial surgery, and postgraduate students who have already selected maxillofacial surgery as their career choice. So without further delay, I would go ahead with the topic. I'll be speaking about what scope as maxillofacial surgeons we have in current era, what are future challenges, and what holds for us in the future. So no talk on surgery, especially in India, can be without a mention of maybe the first maxillofacial surgeon recorded on date. It is the 6th century sage Sushruta, who has a long history of documenting his maxillofacial and facial plastic surgery cases. He has documented each and every steps of various surgeries performed, and he very proudly, as a surgeon, says that surgery has the superior advantage of producing instantaneous result, and hence it is of the highest value in all medical tantras. It prolongs human existence on earth and helps men fulfill their missions successfully. Oral and maxillofacial surgery in India has come to the fore in leaps and bounds. It was initially started by the father of maxillofacial surgery in India, Dr. Mino Jinwala, in 1950s. He was trained in Canada and landed on the shores in Mumbai, started maxillofacial surgery practice in Nair Hospital, and soon many programs catering to education in oral and maxillofacial surgery started across Indian major dental schools, and Government College and Hospital Mumbai being the first one to start a postgraduate course in oral surgery that time. Association of Oral and Maxillofacial Surgery India was founded in 1969. currently the education and the conduct regarding the private practice of maxillofacial surgery in India is monitored and controlled by Dental Council of India. It offers a 3-year comprehensive post-graduation course in oral and maxillofacial surgery at various training centers, teaching centers across India. Unlike the European countries where maxillofacial surgery is now established itself as a specialty of medicine, in India, maxillofacial surgery is still practiced as a specialty of dentistry, and the Dental Practice Act provides unrestricted access to the practice of maxillofacial surgery in its full scope. Once you are duly qualified as a maxillofacial surgeon, you practically gain a license to practice maxillofacial surgery in all its scope. So the scope is very vast. It has a unique position in that it does a lot of work as ambulatory service or OPD service or maybe in clinic, and a lot of work is done as a hospital setting where it caters to a large variety of patients suffering from maxillofacial ailments and pathologies. So without further delay, I would like to enumerate the core practice, what we learn and follow after graduation and once we enter a dental school for specialization in maxillofacial surgery. So extraction of teeth with minimal trauma, guided by all basic principles of clean surgery, soft tissue handling, sectioning of the teeth, minimal trauma to the bone, principles of flap elevation, and that is the first part of surgery, what we learn as a postgraduate student. We do get a lot of surgeries from allied branches like orthodontia, and we have to do a lot of extractions, impactions because of the patient needs orthodontic treatment. This is a case of canine impaction, palatally impacted canine. This is being planned for orthodontic correction. You are basically trained to handle the soft tissue and hard tissue in a unique manner once you are trained in maxillofacial surgery. Sectioning of teeth, traumatic elevation of soft tissue flaps, vascularity concerns, good suturing technique, all are imbibed during the years we practice and learn maxillofacial surgery. This again is an orthodontic case where orthodontic positioning of impacted maxillary canine is to be done. It requires careful elevation of soft tissue flap, approximating the position based on CT scan and X-rays, CBCT scan, and creating a window on the palatal bone, attaching orthodontic wire, and then create an ideal environment so that the orthodontist can take the tooth out and bring it into position. As a maxillofacial surgeons, we come across a lot of benign jaw pathologies, most common being cysts of odontogenic origin, careful elevation of buccal and palatal flaps, careful elevation and enucleation of the cystic lining, preserving the surrounding anatomic structure, reapproximation and good suturing is what we do many times, and use of intraoral drains. I like to use intraoral drains for evacuation of hematoma. So this lots of dentoalveolar surgery that we practice. With the advent of implantology, more and more oral surgeons have taken up to implantology and jaw rehabilitation using implants. As a postgraduate student, every postgraduate must concentrate on learning principles and basics of oral implantology. The first case is an edentulous mandibular ridge, and I have done intermental implants restored by a hybrid prosthesis. The second case is a very young 18-year-old patient with loss of posterior teeth I have used two osseogenetic integrated implants, good bone height, no guided bone regeneration required, and a good outcome. Again, implantology, you get a lot of challenging cases. Sometimes there is intermental width issue. The width of the bone is sometimes not adequate, and you have to do an additional procedure like a ridge split procedure to horizontally augment the arch to receive implant, and then guided bone regeneration in the form of autograft, allogenic graft, adaptation of resorbable membrane, suturing, and then the prosthetic phase to rehabilitate the patient with with an implant-supported prosthesis. Then, as oral surgeons, we get to do a lot of procedure where there requires bone augmentation. Especially here in this case, the maxillary anterior bone loss is of a great deal. Ridge split is not possible, and hence an intraoral chin graft has been harvested from the mental region in the chin, and it's been grafted in the maxillary anterior area to receive implants. Sometimes in the posterior maxilla is a precarious region. You get pneumatization of the maxillary sinus, and many a times indirect sinus lift is not possible. You have to go ahead and do what is called as a direct sinus lift procedure, which with the advent of piezo surgery has become a very safe and easy, convenient procedure. In this particular patient, it's a big window of sinus elevation required. That's the sinus membrane, and you can appreciate the branch of the posterior superior alveolar artery, which is passing onto the membrane here. Since the height of bone available was about 5 millimeters in height, we could do primary implantation and then guided bone regeneration using alloplastic bone graft and a membrane, and that's a close result. As maxillofacial surgeons, we get to handle a lot of facial-maxillary trauma. The uniqueness of maxillofacial surgeons' approach to treatment of trauma is use of intraoral incisions, minimal facial incision, aesthetic incisions, and attention to detail for occlusion. So this is a case which, as a postgraduate student, a lot of trainees must be doing, is intraoral open reduction and internal fixation at the Chamfy's line for fracture angle of mandible. And then we get a lot of complex trauma like the subcondylar fracture, condylar neck fracture, which are low in position. We majority of the time use post-ramal incision and fix the condyle in position. We get mid-facial trauma. I'm not putting up those slides, but the most precarious one and extremely difficult and challenging is to reconstruct the orbital floor fracture. Transcendentile incision, the orbital floor is repaired using a titanium mesh. With the advent of stereolithographic models and patient-specific implants, now the accuracy of these orbital floor corrections has improved drastically. You can see the post-op CT scan where it's been exactly positioned. We get complex trauma because the nature of trauma is now changing. A lot of people are using seat belts. Helmet wearing is compulsory. So whenever we get patients with facial trauma, they are either injuries which are extremely dangerous because it is all high velocity trauma, and we do get fracture of the frontal bones and complex defect, which we can use patient specific implants using 3D printing techniques and adequately restore. As maxillofacial surgeons, we get to treat a lot of odontogenic infections. Sometimes we have the first case shows an odontogenic infection comprising of buccal, masseteric, as well as left submandibular space drained with a minimal adequately placed incision and pus is relieved. The second case is most unique and handled very well by maxillofacial surgeon is use of intraoral incisions to drain spaces like the pterygomandibular space and sometimes the buccal space. You don't need to give any extraoral incision. Strategically place safe intraoral incision to drain the abscess works wonders aesthetically and functionally to the patient. Last year, lot of patients post-COVID had this trouble of mucormycosis related or fungal jaw necrosis. Initially, we never used to see so many patients, but something in the disease and its management of COVID led to an epidemic of maxillofacial mucormycosis. This is a particular case. The case is primarily treated with judiciously aggressive surgery where you take out the necrotic maxillary bone, involve teeth, try to save the vascular tissue. In this particular case, since the maxillary posterior area is vulnerable for oroantral communication, as a maxillofacial surgeons, we are very well trained in harvesting local flaps. So a two-layer closure at the maxillary tuberosity area by buccal fat pad and then the mucosal closure has worked wonders in this case. So once we take out portion of maxilla, either you have an option of using autogenous bone and then implants, and sometimes patients are too old and they have comorbid conditions, then we use the zygomatic implants. The zygomatic implant, again, nowadays we are taking more and more use of stereolithographic model and 3D printing. For patient-specific implants, this patient is restored by using zygomatic implants where the entire zygomatic bone is used for taking support for the implant and maxillary denture is fabricated based on that implant, gives excellent functional and cosmetic result, and it is minimally invasive, can be given in patients where they are not fit for a major surgery. Orthognathic surgery brings the uniqueness and has added major charm in the practice of maxillofacial surgery. This particular patient, if you see, has excess mandibular projection and he has been treated by mandibular setback procedure. There is nothing done to the upper jaw, but the moment you set the lower jaw back into its natural position, the upper jaw looks full and the entire facial contour changes. You can use patient-specific CT scan to do all the planning, and you can plan of osteotomized segments in such a way that you don't encroach on the posterior pharyngeal space and land the patient up with sleep apnea. This is again an orthognathic surgery case where the excess the excess projection of mandible, you need to move the maxilla anteriorly and take the mandible back so the defect is shared. And this is a post-operative result. Pre-operative occlusion, post-operative occlusion. The facial contour is in balance. The zygoma nothing has been done to the zygoma, but the projection looked fantastic, and the patient's entire facial appearance has changed. Plus, the occlusion has become more natural, and it ensures longevity of the masticatory apparatus. Temporomandibular joint surgery is again very unique to maxillofacial surgery. This is an adult patient untreated for ankylosis of right temporomandibular joint. Again, we are using a lot of technology. We are using patient-specific temporomandibular joint replacement. And in this case, we first release the ankylotic mass, that is a ankylotic mass exposure. Then we have these cutting guides which guide us about how much ankylotic mass is to be excised. and there is insertion of patient-specific implant. Am I audible? Then going ahead, we treat.
Yes, sir, you're audible.
I heard some commotion, so I thought something is being told. Okay, I'll proceed. So, as a maxillofacial surgeons, we get a lot of benign jaw pathologies. This particular patient, a young 13-year-old boy, has aneurysmal bone cyst in the left side of maxilla, and it's been treated not by a Weber-Ferguson kind of an approach, but per oral approach, and with the use of endoscopy, we can access all the areas close to the orbital areas as well as close to the greater wing of sphenoid. This particular patient in the post-op period had a breakdown of the wound, and temporary obturator has been given during the healing process. Now, again, a benign lesion of the jaw, most common lesion, ameloblastoma, 21-year-old patient, gross deformity of the face. He will require disarticulation segmental mandibulectomy left side because the lesion, we need to take at least 1 centimeter margins all around. We have planned for fibula reconstruction and implants in the same go. This is the cutting, determining the osteotomy cut. All these planning is done based on patient CT scan. DICOM data is obtained, and we fabricate all these cutting guides in the lab and execute it on table. So this is the end result. We have fixed the fibula in the desired position, and we have fixed the implant in the same sitting in one go. This is a pre-op appearance. That's a post-op appearance. This is a post-op orthopentomograph showing excellent occlusion, and the defect is restored later after 6 months once the implants osseointegrate. This again a case of congenital maxillary hypoplasia. The patient never had a normal maxilla, and she is a 18-year-old girl. Looks. There is absolutely no nasal support because of absent maxilla. She looks old. That is what her complaint was. So these are her baseline scan. Based on that, using certain imagination, we created a maxilla on top, created a template for a fibula reconstruction, fibula harvested and fixed in the form of taking guidance from the template, osseo-integrated implants, and look at the facial projection now. Nothing has been done to the nose, but the lip support and the nose support, because of new bone on osseo-integrated implant and prosthesis, has given a new shape, a normal shape, near normal shape to her face. As maxillofacial surgeons, we come across a lot of salivary gland pathologies. This particular case is a low-grade neoplasm of left parotid gland and acinic cell carcinoma. And I've done a superficial parotidectomy. That's the facial nerve, and the tumor is dissected completely out. We need to be very well oriented with the oral medicine because a lot of patients with a lot of oral mucosal pathologies do visit maxillofacial surgeons, and we all should be well aware of various pre-malignant conditions in the oral cavity. Dr. Hitesh will, with the next speaker, will throw light on this more in detail. A notorious disorder, again, a potentially malignant condition of the oral cavity, that is oral submucous fibrosis. This is attributed to use of areca nut in the form of supari, gutka, or pan masala. It leads to progressive fibrosis, oral mucosa and the musculature around, and leads to progressive trismus. And patients do complain of reduction in mouth opening over a period of time. There is no cure for this condition. The surgery is aimed only to improve mouth opening so that patient can take care of his or her oral hygiene and improve their diet. So there are multiple choices. We being maxillofacial surgeons are trained very well in local and regional flaps. So in this particular case, bilateral coronidectomy, and after that buccal fat pad has been harvested. Look how beautifully the fat pad has mucosalized and patient has got improved mouth opening. Again, oral submucous fibrosis case, we have harvested bilateral nasolabial flap and have given good mouth opening. This case, I have borrowed it from a friend from Nagpur. He has we as maxillofacial surgeons harvest lot of subplatysmal flap where the incision is taken low in the neck. There is no visible scar on the face, and the vaccinator subplatysmal flap is harvested in the platysmal flap is harvested in the oral cavity. We can use submental flap, and I borrowed this case from Professor Kiran Gadre from Pune. Oral malignancy, I think Dr. Hitesh will go in great detail of the oral malignancy cases. Oral cancer is #1 cancer in India, and as maxillofacial surgeons, we come across lots of patients with oral cancer. Sometimes patients are not affording, they cannot primary closure is done, patient will have microstomia, patient cannot afford a free flap, so an cylinder flap has been done. Some microstomia is a result, but the cosmesis is much better. And with the cylinder flap, one advantage is there is no drooling of saliva. Competence is maintained. Again, a lower alveolus lesion, bilateral nasolabial flaps have been harvested, and patient has got good mouth cavity. I do not recommend submental flap for invasive squamous cell carcinoma. This particular patient has a verrucous carcinoma in the lower labial mucosa going on to the edentulous ridge. This is an excised tumor. We have harvested the submental flap. He required an additional cylinder flap, and that's the final result. The uniqueness of maxillofacial surgery and the local anatomy gives us an added advantage that we can do maxillectomies without any extraoral incisions, provided patient has got good mouth opening. This particular case is a case of a salivary gland neoplasm, a high-grade mucoepidermoid carcinoma of the palate, and per oral maxillectomy, inferior infrastructure maxillectomy with ITF clearance has been done, and we have harvested vaccinator myomucosal flap and closed the defect primarily. The prerequisite for harvesting this flap is patient should not have submucous fibrosis and should have good mouth opening. This is again a microvascular flap reconstruction. We have harvested a microvascular flap, free radial artery forearm flap from the hand and created the upper lip defect. This is the final defect. There is initially some drooling of saliva. Competence is the issue initially, but as patient learns to use his oral commissure in a better way, the drooling reduces. This again the most common cancer, the gingiobuccal cancer, and it's been treated with microvascular free fibula flap. Everything done primarily bone after doing the neck dissection and resection of primary with good margins. Bone as well as soft tissue and skin is harvested from the leg along with the artery and vein. A pre-contour mandibular plate which gives exact shape of the mandible, and this is the appearance of the patient after completion of radiotherapy. Sometimes some patients are not fit for microvascular reconstruction. They sometimes do not afford microvascular reconstruction, and then we have only one stay, that is use of a very robust regional flap in the form of pectoralis major myocutaneous flap. It can give a good intraoral cover as in the first case, and it can give intraoral and as well as extraoral cover as in the second case. This case, this gentleman had a buccal mucosa cancer, primarily a soft tissue disease with paramandibular spread, required anterolateral thigh flap because PMMC, the defect would not have been possible to close. A big extraoral and intraoral paddle and anterolateral thigh flap has been harvested from the leg and reconstruction has been achieved. Now, there are other areas like cleft lip palate and craniofacial surgery, which has been adopted as the mainstay treatment expertise by many of the maxillofacial surgeons. This is a case which is borrowed from a good friend of mine who has been practicing exclusive craniofacial and cleft lip palate surgery for past many years. And now maxillofacial surgeons are the main torch bearers in treatment of cleft lip palate in India. With the advent of aesthetic facial surgery and hair transplant, a lot of maxillofacial surgeons have been trained in doing these procedures and are practicing it on day-to-day basis with excellent practice. This is a case which is a hair transplant case borrowed from a friend of mine, and it is a 4-year follow-up, stable, good result. A lot of cosmetic facial surgery is being performed by use of rhytidectomy, brow lift, contour threads, Botox, and there are many maxillofacial surgeons who are doing excellent practice in improving facial aesthetics of lots of patients. And this is a case again borrowed from a cosmetic surgeon, maxillofacial surgeon in Mumbai. So I don't want to get into a lot of technical details and tell you about how complex the entire branch is. Dr. Laskin has defined the concept of expertise, concept of competence and familiarity. What he says is that as maxillofacial surgeon, we have expertise in oral medicine, oral pathology, dental surgery, pre-prosthetic implantology, and maxillofacial trauma. We need to have adequate competence in orthognathic, temporomandibular surgery, and local flap for reconstruction. Now, what exactly do you mean by expertise, competence, and familiarity? Expertise is expert knowledge, competence is just short of expertise, and familiarity is deep knowledge but scope for improvement in surgical and clinical skills. But this classification put up by Dr. Laskin is now become a debatable issue because lots of maxillofacial surgeons after their post-graduation are getting trained in areas which were initially considered as areas of familiarity and converting these areas into their expertise and skill for day-to-day practice. So I do not want to go into big detail. The scope of maxillofacial surgery is unlimited as long as you practice it ethically with patient-centric approach, and you need to be upgraded with current knowledge and evidence-based safe practices. Challenges, I could have given a big list of challenges, but to my opinion, all the challenges are surpassable with adequate knowledge, training, and gaining excellent skill, and follow your own path with passion, perseverance, and patience. Future is bright. Thank you.
Thank you, Dr. Sagar. It was a really wonderful presentation, and I'm sure all our participants will definitely benefit from it.
We'll take the questions at the end of both the lectures, or
I think that's a better idea. That will work.
Yeah.
Thank you, doctor.
Thank you, Dr. Sagar sir, for a very informative session. I hope it will turn out to be very helpful for not only our undergraduates but also postgraduate students. On behalf of Government Dental College and Hospital Mumbai and Department of Oral and Maxillofacial Surgery, We would like to present you this online certificate as a token of appreciation. Moving on with today's last oration on the topic Overview on Prevention and Treatment of Oral Cavity Cancer, I request Dr. Jayant Landge sir to introduce our next speaker, Dr. Hitesh Singhvi sir.
Good afternoon. I would like to introduce Dr. Hitesh Singhvi. He is very young and enthusiastic maxillofacial surgeon and trained in head and neck oncology. He is undergraduate from GDC Mumbai. He has done his fellowship in head and neck oncology in Tata Memorial Hospital, Mumbai. He is ex-research associate from University of Minnesota. He is having 54 national and various international publications. Dr. Hitesh having special interest in oral cancer prevention and treatment. And currently he is working as a consultant head and neck surgeon, Fortis Hospital, Mulund. So I would like to call upon Dr. Hitesh Singhvi. He will be enlightening on overview on prevention and treatment of oral cavity cancer. Thank you.
Thank you, Dr. Jayant, for that introduction. At the outset, I would like to thank Dr. Samir Kinde sir, Dimple madam and Ishwaran sir for giving me this opportunity to present in my own mother institute. I call this as a mother institute because that is where I have learned, I have grown up in my first initial years. I would also like to thank Dr. Sagar for inspiring me to take oral cancer as a niche for a niche practice. I would like to thank Dr. Sanjay Joshi and Dr. Seema madam for guiding me through oral maxillofacial days. And lastly, I would like to thank Dr. Pankaj Chaturvedi and Deepa madam for training me in head and neck oncosurgery. So today, topic for me is overview of prevention and treatment of oral cancer. Let me share the video. Let me see if it's working. Is it working?
It's working.
Thank you. So, firstly, Dr. Sagar has given an exhaustive presentation of what is the scope of oral and maxillofacial surgeon is, right from dental extraction to major surgeries like cleft surgeries and oral cancer. I would be lighter on that topic. I would first give you what are the ways in which a dentist or a maxillofacial surgeon play a big role in the management and prevention of oral cancer. So contents include, first is what is the incidence and epidemiology of oral cancer, overall anatomy of the oral cavity, what are the etiologies of oral cavity cancers, how dentists are the safest bet in prevention of OCC, what are the risk factors of oral potentially malignant disorders. I am very staunch on showing you the video of how to examine the oral cavity, especially how you can train your patients to examine the same. What are the symptoms of oral cavity cancers? How do you work it up? And in general, what is the treatment of OCC, and index small cases to show how it goes. So let me begin. So oral cavity cancers. Oral cavity is a distinct site of head and neck region that possess complex functional anatomy with regards to speech, swallowing, and facial projection. Anatomically, oral cavity is composed of 7 parts: mucosal lip, oral tongue, floor of mouth, mandibular and maxillary gingiva, retromolar trigone, buccal mucosa, and hard parent. Although oropharynx is often confused as a continuous extension, but it is a separate site, even according to ICD. So just to show you what are the exact size of head and neck, oral cavity is part of it. It also includes paranasal sinuses, nasopharynx, oropharynx, hypopharynx, and larynx. To start with epidemiology, just to give the gravity of situation which we are facing, oral cancer is a silent pandemic. Why? Because in India, oral cavity is the most common cancer in males and third most common cancer in females. India is called global oral cancer capital with more than 1,20,000 new oral cancer cases arising every year. And more importantly, especially in Indian subcontinent, 70% of all these cancers are advanced stage. And that is the reason why 50% of all these diagnosed oral cavity cancer die within first year of diagnosis. So all these factors, all these facts are derived from those which are reported. So you can imagine the number which is unreported. So according to a global adult tobacco survey, now why India is called global oral cancer capital, you know about it because I've told you that there are so many cases arising every year. But why so many cases arising every year is because 1/3 of all the adult Indians. So if you count 100 crore adult Indians, of them 1/3 they all consume tobacco in some form. It can be combustible or smokeless tobacco. 70% of all these tobacco users are smokeless tobacco. So, coming or squaring it down, smokeless tobacco is one of the major reasons of oral cavity cancers in India. So, current scenario, as I have already told you, 21% of adult tobacco of adults they consume smokeless tobacco, while only 9% and 5% they smoke or they do both respectively. Just to give you an overview of what are the etiologies, tobacco, which we have already shown you. Second is areca nut, also known as supari, also known as betel nut, is a class 1 ISC approved carcinogen. That means it independently can cause oral cavity cancer. Third is alcohol. We have our own meta-analysis which is published in Indian Journal of Cancer, which says that even alcohol is a class 1 carcinogen and also is as cancerous in Indians as compared to the Western population. Fourth and fifth are not the etiologies of oral cancer, but they are contributory factors. There is no level 1 evidence to support that, but we still have reviews which says that even chronic mucosal trauma because of ill-fitting dentures, because of sharp tooth, have been observed to be associated with oral cancer. And same goes for poor oral hygiene. So just give you, we'll just play with the numbers. How many times does tobacco have an influence on carcinogenesis, especially in oral cavity? So if you see, if it is nasopharynx and upper digestive tract, it is 3 times and 2 times. If it is pharynx, it's 6.7 times. If it is larynx and lung, so it's 7 times higher chances of carcinogenesis in the patient who is using smoke, who is using cigarettes, and 9 times it is in lungs. So these facts are good for Western population, but is it suited for Indian? So smoking is dangerous. There is no doubt about it. But whether smokeless tobacco is safe, absolutely no. Smokeless tobacco is as dangerous. It's very important that we highlight, even our students, even our patients, that smokeless tobacco is as dangerous as smoking, and you should not take it as a surrogate or a safe replacement for smoking. So just to give you some facts, that smokeless tobacco is 5 times the individuals who consume this areca nut with tobacco is 7 times. They have 7 times higher chances of oral carcinogenesis. But even if you consume areca nut on a daily basis without tobacco, it is still 2.8 times higher chances you will have oral cancer. And more importantly, even if you don't have oral cancer, you might develop oral submucous fibrosis. So such is an observation. This is my observation, where you see the green part. This is a world map where green part, where there is a high incidence of, or it is color coded according to the market of areca nut, that is supari. So if you see the green part, green color of the countries which have high production of areca nut, and you correlate it with the incidence of oral submucous fibrosis is absolutely congruent. So such is an impact of even the market of arecanut on the incidence of oral submucous fibrosis. The clinical conditions which I've already seen in Dr. Sagar's presentation. So just to give you the facts on how different type of tobacco products have impact on oral carcinogenesis is gutka is very dangerous. It is 9 times higher chances of cancer. Betel liquid is 7 times. Oral snuff is 4 times. Mandatory tobacco is 3 times. Alcohol is as dangerous. Many even publications have sometimes I would say misled our medical fraternity that even in small quantities alcohol is safe, but it is not. Alcohol in any quantity is not safe, is not healthy. So we did a study, we did a meta-analysis just to find out whether Indians behave in the same way, and the answer is the yes. So alcohol can cause cancer to the range of 2.3 times and oral cancer to the range of 2 times, even if you don't consume tobacco. So other contributing factors like ill-fitting dentures, poor oral hygiene, which I've already described, and of course viruses. Still no publication, no evidence to support that HPV can drive oral carcinogenesis, but HPV infections are found in oral cancer. So now the next question, which I feel is very important, on how dental professionals or physicians can play an important role in prevention of oral cavity cancers. So you see oral cavity day in and day out. You see usual ulcers, you see homogeneous leukoplakias, you see converting them into a big plaque and then converting into erosive, or I would say an irregular leukoplakia type of an ulcer or lesion, and then into a frank oral cavity cancer. So you know exactly how it proceeds from a precancerous lesion to a full-blown oral cavity cancer. So why we think, or why I think dentist is the safest bet for this job, especially for prevention and also for treatment of oral cancer, is because they know the oral anatomy very well. They have spent about 5.5 years just to learn and study about oral anatomy. They know the clinical and pathological factors of oral potentially malignant disorders. They know how it proceeds. They know the way of oral carcinogenesis, and also the numbers support us. According to WHO, we need a ratio of 1:7,500 dentists. In population, we have 1:5,000. So we have a good strength and manpower. We need to just channelize them into this field. So just to tell you the effect of screening. So when you screen an individual, and especially then a high risk individual, when you see in OPD who is consuming tobacco on a regular basis, who is consuming alcohol, who has sharp tooth or inflated dentures, and who is not maintaining his oral cavity well for hygiene, in those cases, the effect of screening is tremendous. It is shown in a literature which says that if you screen such high risk individuals well, we will be able to save 37,000 individuals every year. That is huge. So this is how oral carcinogenesis takes place. The upper slide, the upper picture is the clinical condition and how it transforms from a leukoplakia to a full-blown ulcers. The mid photos are the histopathological slides on how it transforms. And similarly, I just wanted to know why are these oral pre-malignant lesion or oral potential malignant disorder it's very important for us to diagnose them, is because these leukoplakias they never regress. So the percentage of them regressing is very low, is as low as 11% in Indian study and 3.3% in international studies. But they either are stable or they progress. And once they progress, there are high chances they will convert into malignancy. So more than 80% of these disease, they will progress. So then if it progresses, then how do we know which leukoplakias are red, are I would say suspicious, or what are the red flags you would need to know in leukoplakias that yes, they should undergo biopsy or they should be kept under surveillance. So female gender without any habits, long duration of leukoplakia, that is more than 5 years, leukoplakia in non-smokers, location, site, that is tongue or lateral part of tongue and floor of the mouth, these are high risk site. When size of the leukoplakia is more than 2 centimeters or 200 millimeters square, it is non-homogeneous type, that is it has a red component to that lesion, present of Candida albicans, and on biopsy there is some epithelial dysplasia associated with it. So these are the red flags. You should know which leukoplakia you should take very seriously. Another concept which I want all our maxillofacial surgeons and also dentists and audiences to know, that we should train our patients, especially the high risk patients, which I've already quoted, which are the high risk patients, on how to train them to self-examine. Now, this idea comes from breast cancers, where the breast self-examination has made a tremendous impact on its early diagnosis, and therefore leading to improved overall survival. Now, if you I would say evaluate that in oral cavity cancer, it will also work well, because oral cavity is seen, it can be seen with the naked eye. Don't need a scope. It is that is the reason why, and it's not an idea. It's already described in study that it works well, especially post awareness programs. It is subject to risk factors like older age groups and low education, especially in Indian scenario, where the patient is not educated enough to do the self-examination. But if they are educated enough to do self-examination, then the specificity rate of this mouth self-examination is up to 99%. So let us see what mouth self-examination is.
In between dental hygiene visits, it's not hard to do self-exam. Step 1. Tongue. Stick out your tongue and hold it at 1, 2, 3. Move your tongue to the right and then the left and look for any red and white patches. The same for the top and bottom of the tongue. Use your index finger to feel for any unusual lumps on the sides, top, and bottom of the tongue. Step 2. Lip and cheek. Look around the edge of your lips for any lesions, sores. Using your thumb and index finger of both hands, pull back the upper lip, red or white lesions, sores. Using these same fingers, feel for any lumps, bumps. Same with your bottom lip. Next, use your thumb and index finger to pull back the right side of your cheek for any red or white patches. Using these same fingers, rub your cheek between them to feel for any lumps, bumps. Repeat on the left side. Step 3. Floor of mouth. Raise your tongue to look at the roof of your mouth and look under it in the bottom of the mouth for any white and red patches. Using one finger inside the floor of the mouth and another on the opposing surface outside chin, feel for any lumps or bumps between the fingers. Step 4. Roof of the mouth. Look at the roof of your mouth for any unusual sores or red and white patches. Rub the roof of your mouth for unusual swelling. Step 5. Head and neck. All 4 fingers to rub in a circular motion. Pull your neck for unusual lumps, bumps, or tenderness. Repeat this on the back of your neck, along your hairline, and behind, under, and in front of your ears. Step 6. Say ah. Press down on your tongue with a tongue depressor or teaspoon. Say ah and look at the back of your nose. Red, white patches or unusual. Step 7. Tell someone. Call your oral health professional and have any unusual findings checked. Early detection.
So this is how you can train and you can train your patients who are high risk individuals on how to self-examine the mouth. It's quite simple. You have already seen the symptoms in the video. Just to repeat it: swelling the neck, slow non-healing ulcers in the mouth, unusual bleeding or pain or numbness in the mouth, voice change, difficulty in chewing or swallowing, persistent facial neck or ear pain, epistaxis or nasal obstruction, loose teeth or ill-fitting dentures. Now, coming back on why oral cavity cancer is a major challenge is because presence of nodal metastasis has the greatest effect on survival, reducing the survival by 50%. If you see, this is the major challenge. So stage 1 and stage 2, the overall survival is more than 70%. Is in the range of 70 to 90%. But since we already know that 70% of all our oral cavity cancers are advanced stage, their survival is less than 60%. Just to give you an overview, what are the investigations which we do is we do CT scans if you want to see any kind of bone involvement, and those are especially in buccal mucosa cancers. While we do MRI with contrast enhanced for soft tissue involvement, and especially in tongue cancers. PET scan has become a widely used tool for detection of metastasis, second primary malignancies, and post-treatment surveillance. However, its use is still controversial in preoperative workup, especially in resource constrained settings like India. So, just to give you an overview, how do we go ahead with treatment of oral cavity cancer? So, early stage diseases, they are normally cured with surgeries, but advanced stage diseases, they require multimodal treatment, which is surgery plus radiotherapy plus a minus chemotherapy. So goal of surgery is complete resection of the primary tumor with negative margins, staging them, and then treatment of regional lymphatics in the form of neck surgeries, neck dissections. So margin status is one of the most important variables which is controlled by us surgeons and which influences survival. This is the only factor which a surgeon can control, which he can control and have an influence on survival of oral cancer. So if you see, to give you a rule of thumb, early stage single modality may be enough, but for locally advanced, it is combined modality of surgery plus radiation therapy plus or minus chemotherapy. So just to stage it, T1 is, we will just discuss the TNM classification. So we normally, for any oral cavity cancer, we classify the patient into a TNM. T is for tumor, N is for nodal status, and M for metastasis. So T1, so it ranges from T1 to T4. T1 is according to the size of the tumor. When it is less than 2 centimeters, T1. 2 to 4, it is T2. T3 is greater than 4. And T4 is when it is invasive or invading its is accompanying vital structures. Similarly, it goes for lip, and same is for tongue. So if you see, just to show a schematic diagram on how the T1 and T2 looks like on tongue and on the lip according to their sizes. And similarly for T3 and T4, T3 is much larger disease, while in T4, if you see T4, it's majorly tongue which is invading the mandible. So when it's involving adjacent structures like bone or into deep extrinsic muscles, skin or maxillary sinus, it becomes T4. So T4B is a little more advanced local disease where it is involving the masticator space like pterygoid plates, skull bases, and where if it is encasing into carotid artery. And just to keep it simple, the staging of neck involves N0, N1, N2, and N3. There have been some modifications in current AJC, which is not in this purview. It's not in the purview of today's presentation. Just to give you an idea where the nodes can be, or what is the classification on which, or factors on which these are classified, is on the sizes. If it is less than 3 centimeters, N1, 3 to 6 is N2, and more than 6 it is N3. So when it is on the same side, it is N2A. On the same side, multiple nodes, it is N2B, and if it is going on to the other side of the neck, or if the size of the disease is greater than 6 centimeters, it becomes N3. So why did I find the need to show you this neural staging is because of this study which we are doing, which is unpublished in collaboration with IDA, TMH Varanasi, and also KLE. We screened about 30,000 dentists. We got responses from 600 dentists, and we found that 64% of all the dentists do not examine the neck after examining the patient for oral potentially malignant disorders or early oral cancer. The good news is that if the dentist or if the maxillofacial surgeon is trained for diagnosing OPMD, then they examine to the tune of about 90%. So it is the need of the hour to train us maxillofacial surgeons and even the dentist to examine oral cavity cancer, oral potentially malignant disorders and early oral cancer, and also examine the neck. So principles I have already discussed. This is how the margins will play a role. The red part, the red demarcations which I have shown is actually the amount of tissue which we will take along with the primary disease. It's almost more than 1 centimeter in all sides in 3 dimensions. Similarly, for T2, in this case, we might have to take even the part of the mandible or alveolus to get good margins. And in this case, when it is actually involving the mandible, you will take tongue and mandible for a complete resection, which is whose margins are disease-free or at least 1 centimeter away. Just to show you a clinical photographs on how it actually looks. So this is a T2 tongue case of right about a tongue which we have resected. You see the resection specimen on the right side is a relatively early stage. And this is an advanced stage where this is almost a T4 disease crossing the midline of tongue. And since even if it is not involving the mandible, we have to take it for margins. So we have taken the alveolus or marginal mandibulectomy for a complete disease-free margins, and also when the margins are greater than 1 centimeter. Another case where it is a composite defect where the disease from the oral cavity has come out of the skin and involved the skin. Here we have completely removed the mandible and the maxilla along with this overlying skin involved with good more than 1 centimeter margin and reconstructed with pectoralis major myocutaneous flap, which was already discussed with by Dr. Sagar. So just to give you an overview in this, we have not taken the skin, we have just taken the upper maxilla and the mandible. On the left hand side of the skin, you will see you're able to examine the complete field cancerization. This case, I especially wanted to highlight the field cancerization part of the tobacco. You see even the right corner of the mouth seems to be involved. We have taken even that, and it was positive for squamous cell carcinoma. Another case where it is CA palate, carcinoma palate, it seemed to involve bilaterally. We had to remove the complete, both the maxillas, along with part of the skin. But importantly, even after 2 years, he is disease-free, and he majorly is able to do all the functions like speaking. He's able to he's on soft diet, but he works well for about 7 to 8 hours every day. Another advanced case where the buccal mucosa cancers has perforated the skin, and in this case again a big resection was planned along with mandible and maxilla taking into it, but and we reconstructed this with scalp flap, and for inner lining we use pectoralis major myocutaneous flap. After 2 years, he is disease-free, and again he retains all the functions. He is working. So for us, very important thing is you not only save the life of the patient, but you also give some quality of life where he is able to win his bread on an everyday basis. So the important message which I wanted to pass on to you in last 2-3 cases was even if early detection is a key, and survival is very good in early detection. Even advanced oral cavity cancers are curable if the patient receives treatment on time. So, if you see any advanced oral cavity cancer, do not shy away from examining it. Examine them, see for signs of inoperability. If it is inoperable, then we can opt for chemotherapy. But do not shy away from not even examining them. So, is surgery for oral cavity cancers enough? You have seen the entire primary disease from the oral cavity, but is it enough? No, it is not, because it also involves the dissection of neck nodes. 50% of all the oral cavity cancers presented in India has nodal involvement, and 30% of all the early oral cavity cancers. So even if you examine the neck, you'll not be able to palpate these nodes. Even 30% of these non-palpable nodes might have nodal metastasis. And that is the reason why we perform prophylactic neck dissections even in early oral cavity cancers, and this is level 1 evidence coming from TMH. Just to sum it up, the next part is radiation after surgery. Radiation is not the primary choice of treatment in oral cavity cancers as a definitive treatment. Yes, but it has a major role in adjuvant setting. Adjuvant setting, that means after surgery, we give patient with radiation, especially in advanced cases, and especially in those cases where certain risk factors which you see in a histopathological report, like perinodal extension, extracapsular spread, perineal invasion, all of the margins are positive. An evolution of radiation therapy is towards decreasing side effects of radiation, right from 3D CRT to IMRT to IGRT to proton-based therapy. We will not venture into detail because it will take another lecture to explain it to you what exactly radiation therapy is. Next is adjuvant therapy. Is primary chemotherapy, has no role again in treatment of oral cavity cancer. That means surgery is the mainstay, which is helped by an adjuvant radiation therapy, and if indicated, chemotherapy as well. So, but chemotherapy now in research setting have shown that they can be given in neoadjuvant setting in borderline operable cases, and studies in research trials have shown to preserve mandible in select patients and also shown to increase operable rates. Now, if you see, even after the oral cavity cancer has been treated well, there are good 30 to 40% chances that they'll recur in 5 years, and surgery is again an indication in salvage, and survival is about 30%. That is the reason why prevention is better than cure. And what I feel is dentist are the safest bet for prevention of oral cancer, and maxillofacial surgeon can be in the forefront in treating or in the surgical team of oral cavity cancers. Therefore, dentists should be trained enough, diagnose, examine different types of leukoplakia and oral cavity cancers, because if you train them in undergraduation, definitely they have an inclination towards maxillofacial surgery. And further, when you train them enough in a head and neck department, like Dr. Sagar, and there are many other maxillofacial surgeons who have trained themselves in head and neck unit, you can definitely be a part of a resection or ablation team. Screening and prevention of high-risk individual can save about 40,000 individuals all over the world, which we have already specified. Now, these are the few videos I would like you to be motivated that even if these resections are disfiguring, they hamper your functions to the core, but you can still give them adequate function to lead a normal life. Let's see what they say. So this guy underwent an hemiglossectomy. Half of his tongue was removed. But this video is about 6 months after surgery, and he's able to speak each and every number right from one print very clearly. Another video is a partial mastectomy defect. So even he is able to speak well. He has no nasal twang thanks to the maxillofacial prosthodontist who has given him a good obturator. Another guy at 6 o'clock is 78-year-old male who underwent a complete bite. That means upper alveolus and lower alveolus removal along with buccal mucosa. And let's see how clearly he speaks. And this guy was an advanced case of left buccal mucosa coming onto the skin, dribbling pus from the skin. He flew down from the Odisha to Bombay, and this is post-surgery 1 year video. See the amount of more mouth opening. Special thanks to the maxillofacial prosthodontist also again, who helped us in giving him a guide bite prosthesis. He's able to close his mandible in good occlusion on the right side. He's able to have food even if there is no mandible on the left side. So dentist as an asset in an oral cavity cancer treatment at different steps. Maxillofacial surgeon trained in head and neck services can be an ablative surgeon. Dentist, dental treatment prior to radiotherapy. We can give the services for complete dental treatment before radiotherapy. Maxillofacial prosthodontist as an obturator after maxillectomies and guide bite prosthesis, and oral rehabilitation procedures like oral osseointegrated implants. A maxillofacial surgeon can play an important role, especially when you want to impart a quality of life to the oral cancer survivors. Along with in collaboration with prosthodontists, we also did a study where Prajurit Kende sir and Sulekha are the lead, in which we have shown that even if you perform osseointegrated implants post surgery, post radiation, they have good survival rate, whether the patient receive radiation or not. That means we should motivate and we should at least take them in a research trial setting to understand what are the factors influencing influencing survival of implants post surgery and post radiation. So on the event of International Oral and Maxillofacial Day, I just want to give you a short statement that maxillofacial surgeons are an integral part of prevention and management of oral cavity cancers. So you should take an inspiration from doctors like Sagar sir, like Prajurit Kende sir, like Sameer sir, to take this field, take an inspiration and passionately involve yourself in training yourself in treating oral cancers. Thank you very much.
Thank you, sir. If there are any queries from the participants to both Hitesh sir and Sagar sir, they can put it in the chat box or they can unmute themselves. Thank you, Dr. Hitesh sir, for providing valuable as well as interesting information on oral cancer. As a token of appreciation, on behalf of Government Dental College and Hospital, Mumbai, and Department of Oral and Maxillofacial Surgery, we would like to present you this online certificate.
Thank you very much.
I now call upon Dr. Shambhavi to render the vote of thanks.
Thank you, Dr. Sulekha. This auspicious day would be incomplete without the grace of gratitude. First and foremost, I thank our beloved Dean Ma'am, Dr. Dimple Padave Ma'am, for being a constant source of inspiration and encouragement. We thank our guest speakers, Dr. Sagar Vaishampayan Sir and Dr. Hitesh Singhvi Sir, who despite their busy schedule have found time to grace this occasion. Thank you for inspiring and encouraging us with your words of wisdom on this special day. My heartfelt thanks to all the heads of various departments and faculty for their valuable contribution, guidance, and encouragement in all our efforts. I owe special gratitude to the delegates and participants who have made this occasion a grand success. Last but not the least, I thank my colleagues for their cooperation in making this function an astounding success. I would like to end this session by quoting our department slogan, "Teamwork is the fuel that allows common people to do uncommon things." Once again, I thank you all for your attention. With this, we have now come to the end of our session.